Great. So I went to PAEA this summer in Washington, D.C., and I just wanted to talk a little bit about my experience. First, just to give you an overview of what PAEA does. I think most of us are fairly familiar, but they're the only organization that represents all of the accredited programs in the country. Currently 196, that's growing. And they provide services for faculty, for students, and for applicants. So they actually work with PASPA, they work with end of rotation exams, they provide assistance for accreditation and curriculum help. So this is the group that I worked with. Tony Miller, some of you might recognize from the Washington, D.C. trip. Athena Abdullah, who was also there on our D.C. trip. And then India Waller, who is kind of an administrative assistant in the government relations department. So I worked directly with the three of them. So just to kind of go over a couple things that I thought were super important about what I worked on this summer were Title VII funding and the Physician Assistant Higher Education Modernization Act. I'll talk a little bit more about each of them. We worked on a number of different things, but I thought those were probably the most important things that were directly affecting us as students. So first off, I want to talk about the Higher Education Modernization Act and the Stafford loan issue. It came out a little pixelated, but what I wanted to point out is that, and some of you may remember this, is PA students receive a lot less funding when it comes to Stafford loans when compared to medical students, dental students, pharmacy students, even public health and health administration, and those two don't even see patients. So basically what we were working on is trying to get PA students up to that same level of medical students, dental students, etc. Because Stafford loans are a lot more student-friendly, interest rates lower, they have less origination fees when you take them out, and so it's something that the government relations department was working on fixing so that we're more on par with them. We did a fair amount of Hill visits when I was there. This one was with Congressman Robert Hurt, and he's a representative in Virginia, and we talked about Stafford loans. I'm there with Athena, as you can tell, Alyssa Hamilton, who is a public health student that I worked with, me, Sierra, who is a PA student from Shenandoah University, and then the congressman. Overall, it went pretty well, but we met with him after lunch, and he basically fell asleep on us partway through the meeting, but otherwise was interested in what we had to say. And then, actually, let me go back real quick. So I also brought up Title VII funding. This is something else we learned about in March, something that I think we should constantly be aware of, and it's the only source of federal funding that directly supports PA programs, so it's something that we constantly need to be aware of, and overall we really need to be educating people about PA students, the importance of PAs, and how we don't have a ton of funding like medical students do, like dental students do, so it's ever more important that we're constantly making people aware of PAs, and I think it's still an issue and still something we need to work on to increase the awareness of it. So here's some resources if anyone's interested. The PAEA website is really great. They have an article on Title VII that kind of breaks it down into layman's terms and is more easily understandable. And then I have the different committees that basically have jurisdiction on these issues. So the higher education funding jurisdiction, number 2, and for number 3, they would have jurisdiction on Title VII. So they're the ones that are going to be voting on increasing funding or not. And then some random things I did when I was there. We had a Bring Your Kids to Work Day suturing workshop, and so we got to teach like kids from 5 to 12 how to suture, which was super young, but they were totally excited about it. And then I had the chance to practice as well, along with my coworker. And then had a chance to meet up with Lisa and Claudia at ABC, which was really fun. So that was a reunion. We went to this restaurant that Obama ended up going to for his birthday the following week. So that was pretty cool. And then got a chance to work out when I was there and do workouts at the Lincoln Memorial at sunrise. And that was really cool. And that's about it.
So like Brooke, I also spent the summer in DC, except I was interning with AAPA. A lot of you guys know about AAPA just because I think we talked about it at the beginning of last year, and we are all members of AAPA. But I just wanted to tell you a little bit more about what they do beyond send you a monthly issue of JAPA and that little shiny pin that we all wear sometimes. So I worked in the Advocacy and Government Relations Department, but there's actually a lot of different components to AAPA. One of the main things that they do is they are just the national organization and representation for all PAs. So in terms of like healthcare events, meeting with other health organizations, both like physician organizations, nursing organizations, insurance groups, all types of healthcare organizations, they help represent PAs and they're kind of just a voice for us. And within like the political realm, it's really important for PAs just to have a presence and for people to continue to be aware of the profession and what we do. They also do a lot of monitoring of upcoming federal and state legislation. So if there's any upcoming legislation that might impact PAs negatively or positively, they're out there working to make sure that we're continuing to make progress and not moving backwards. They also do research, so they're involved with the annual salary report that a lot of you may have seen and a lot of us will probably use in the future. And then they also put on some CME and education events. So in general, it's just really important to keep up with membership and support the organization that is really in that supporting you guys and supporting us as a profession. This is a state advocacy team that I worked with. So there are 4 state directors, and each one is in charge of a different region of the United States. There's the Western region, the Eastern region, the Midwest, and then the South. And then, as well as some constituent organization and advocacy directors as well. This is a federal team. A few of you, I think, met Tilly when we went to DC for spring break. She is really great, and she is involved with the government relations aspect, so this is more federal stuff. And then Sandy does a lot of the lobbying on the Hill, along with one of the other lobbyists that AAPA employs. So why does AAPA matter, and why does advocacy matter in general? Basically, mostly because it's going to actually affect how we practice on a daily basis. So one of the issues that I wanted to bring up was the scope of practice. So I know we talked about this in DHS, but just a quick refresher. In terms of scope of practice, there are pretty much 6 key elements that we're aiming to achieve. So we want licensure as a regulatory term, full prescriptive authority, and then we want scope of practice, chart code signatures, and the number of PAs that a physician can supervise to all be determined on a practice level. This makes it so that we're not unnecessarily limited by like specific laws that say, oh, you can only have like 2 PAs per physician. This way, like it's really dependent on how your practice operates, which is how we want it because every practice is different and every practice needs different things. So this is a United States map of where we are in terms of each state achieving these 6 elements. So as you can see, California is yellow, meaning we've achieved 4 of those 6 elements. So we're not doing terribly, but we can also improve as well. There are some states that have 6. You can see in some states that still only have 1 or 2. So what are we missing? We're missing chart code signature. We currently require 5% of all charts to be signed in 30 days. And we're missing physician supervision ratio. Currently it is 4 PAs per physician. So these are things that will hopefully be changing in the future and just keep in mind when you're practicing. And also if you want to practice in another state, just make sure you know the scope of practice laws for your state. Other really cool topic-specific issues that I had a chance to work on this summer included one that was relevant to us here in California. So right now, California PAs are having a really hard time being hired in the NICU and the PICU, and this is due to a state-specific organization called CCS, which is California Children's Services. They currently don't recognize PAs as panel providers. They do recognize NPs, and generally they only hire NPs to work in their NICU and PICUs. And this is really due to just like older regulations where PAs were not utilized as much, and they're still concerned about the specialty training that NPs receive in comparison to PAs who do receive slightly more generalist training in a lot of cases. But in general, we're still working to combat this. So what I was working on was I was contacting PAs in different areas of the country and putting together their scope of practice and their bylaws for whichever hospital or clinic they were working at. And just showing and trying to put together a research document that showed CCS that PAs are allowed to do this in so many other different states, and we're capable of working in the NICU, and there's no reason why we should have these unnecessary restrictions placed on us just in California. So currently, they just had a meeting with CCS, and things are going well, and they're still trying to move forward and get that regulation changed. So at the end of the day, what I took away from it, and what I think you guys should maybe take away from this too, is that there are just more PAs that are needed in advocacy and in leadership. Like stand up for your profession, and whenever you see the opportunity to advocate for PAs, like take it, you know, like educate people about what PAs do and our scope of practice. And in terms of hospital leadership and management, get involved. Like if there's an opening to be on a hospital board, if there's an opening to be a director, like take that opportunity, you know, like if someone says, oh, well, we usually only have nurses doing that, be like, what? Like why can't a PA do that? You know, like make sure that you know what you're capable of and that other people know it too. At the end of the day, like that's what's going to push our profession forward. We're still young, we're still growing, and you know, a lot of people might not know everything about us, and that's okay. It's just our job to change that, you know, and it's our job to make sure that our profession keeps moving forward. So for more resources, you can check out the AAPA website. The advocacy section has some really good information. And then if you ever need help, you can always contact AAPA. They have so many resources. In terms of the California NICU stuff, like one of the reasons that I was put on to work on that project was because we had PAs in California contacting AAPA saying, hey, you know, like I just moved to California from Connecticut and I'm trying to get a job in the NICU where I've worked for like 30 years. And I can't because they won't hire me. So like AAPA will put people to work on trying to combat that issue and try to support you in whatever way that they can. So our state advocacy director for the Western region is Keisha Pitts, and you can find her email or her contact info on the AAPA website. And then this is just some fun stuff. I got to go to the Embassy of Austria for their summer ball gala, which was really cool. We learned how to ballroom dance. Probably the fanciest event I've ever been to. And then that is a hearing or a briefing on right after the gay marriage passed. And then this is 4th of July, met up with Brooke as well, and we saw the fireworks on the mall, very patriotic. Yeah, that's it. Thanks for listening, guys.
So Jess, Cheryl, and I did a program called the GE, which stands for General Electric Foundation's National Medical Foundation's Primary Care Leadership Program. So this was a program where it was a 6-week-long internship, and they had various sites throughout the country. I think there was something like 15 sites, and they chose 75 students who were either medical, nurse practitioner, or physician assistant students. So we all each got placed at a various site. I got placed in upstate New York at Rochester, Cheryl in LA, and Jess in Seattle. So just to tell you a little bit about this program, this would be really valuable in case your PA pals ask you about this, and personally I would highly recommend it. So the time requirement is 200 hours. You wind up doing an independent research project, and you have other various leadership curriculums and webinars built into it. The whole point is to understand what goes on behind the scenes of a federally qualified health center, so that to encourage students to go into primary care. So a little bit more about my specific program now. Okay, so in terms of my site, this is kind of where I spent the bulk of my hours. I would go to a lot of meetings with my site supervisor, which was really cool because you get to sit with all these CEOs at business meetings and just hear what they think about healthcare and about how Obamacare has affected their practices and how it affects health disparities. So that's an example from up there. This is a little dark, but I actually got to go to a medical rep dinner, which was a super swanky thing in this wine cellar that was really exclusive. And the ceiling was actually glass, so you could look up and like kind of look up people's skirts. It was a little awkward, but it didn't look up. So Rochester specifically accepts a large refugee population, which is really interesting with all the stuff going on in Europe nowadays. So Rochester accepts 800 new refugees each year from these countries, mostly Nepal, Burma, Bhutan, Somalia, Iraq, Cuba. So just to give you a little background on that. Thanks. So I actually had 2 different parts to my project, and I'll pass these out. You guys can just pass these around. So part 1 is these basically the whole point of it is that all these refugees coming in from these overseas countries don't speak English. So what they have to do in every single office visit is they have to call into this telephone interpreter system, and then it's a really slow process to have the medical provider speak to the telephone interpreter and then get it translated, and then it's kind of a back and forth thing. So I had looked at ways to improve efficiency with that. So this first thing is a labor and delivery system. So all these women would go into labor and delivery, and they wouldn't be able to speak, and they wouldn't be able to request what they wanted to do. So I developed these cards where they can just flip to something and just have that be a really simple way to communicate their desires. And we've heard stories about women getting epidurals who didn't want epidurals because she didn't know how to say no and there wasn't anyone available for her language. So that was what this part one of my project was. This is a little bit about the results, but I'll skip over that in the interest of time. Basically, it was very well received. Okay, so this part 2 of my project was in a primary care clinic. So I examined the 7 most common complaints, which were things like dry skin, GERD, diabetes. So these providers found themselves explaining the same things over and over again, and the patients weren't retaining what they were told in the clinic. So I developed this a few handouts, which are also being passed around. And it just had really simple stuff, like for example, dry skin. Imagine going to a new country and trying to remember a brand name in a foreign language. It's really hard to do. So these patients could take this handout and just go to the grocery store and then match up the picture with what they were recommended to get. So this system of folders was a way to put it in the exam room, so providers could do patient education in the exam room, and then the patients could just take it home with them and hopefully increase patient compliance, patient understanding, and all that. This one was also pretty well received. And next slide. Some fun stuff. It was really cool to go, this picture over here on the left is the other scholars who are also at my site. I had 2 medical students from Howard University in DC, and 1 nurse practitioner student from GWU in Washington, DC as well. So it was really cool getting to interact with them and learning about their programs. And then just as a side note, to encourage people to do this in the future, I took every single weekend off and just traveled all over the East Coast, and I hit a bajillion different cities, so I would really highly recommend it.
To Seattle, which was great because the weather was gorgeous. But I worked in a community health center called Health Point, which is south of Seattle. So when you think of Seattle like the Space Needle, it's 30 minutes south of downtown Seattle. And they had 13 clinical sites, but they were very well developed. Like when you walk in, everything's brand new, and they have a lot of funding. And they're also qualified for NHSC, like overpayment, so a lot of their providers are fulfilling their requirements through the NHSC overpayment program. My project in particular was assigned to their call center, so because they were well developed, they have assigned staff to work in a call center and take in appointment calls, like make appointments, and they're just like the central communication hub. But there were a lot of flaws in terms of their protocols, and they were assigned to all these 13 different sites, but they each had their own set of protocols. So it wasn't very consistent as one set organization. So my goal was to figure out how I could determine barriers that would impact patient care. So it wasn't necessarily direct patient care like, oh, I have to manage your medications. It was more of how can I improve communication between patients and their provider, as well as like the call center in between. So a lot of the barriers I identified was, yes, they were inconsistent protocols, so each clinic had their own set of rules, and made it frustrating because the call center agents were responsible for knowing all the different sets. So I was just trying to make it so that it was consistent throughout. And I also did a lot of investigating throughout my 6 weeks of working with their EHR system, which they use NextGen. So I had to contact a lot of NextGen employees to figure out what certain ways would make it easier for patients to call in and access their patient chart. Oh, excuse me, patient chart. Another thing that I had to implement was going through their phone log or their phone tree. So when a patient calls in, they have all these options of like, I want to make an appointment or I want to refill a prescription. But then when I called in myself, any button that you choose or a patient chooses, it just gets redirected to the same person. So it's not really effective in that sense. So I had to do more investigating and ask the phone tree to be reconfigured. But aside from figuring out all the details of like what went wrong between communication between the front office and the back office, I did a lot of shadowing, so the clinical aspect as well as the admin aspect. I was in administration for quite a bit. And it was more of a meeting with the CEO and all these board members who are in leadership, because it's primary care leadership, so you talk with all these medical providers who are part of the board, who are implementing these changes in order for them to improve patient care. And it's a lot of interdisciplinary work, so I got to work with the other interns, there are MDs, DOs, and another PA, as well as the providers themselves. And so you get to sit in on a lot of meetings to figure out what changes they're making in order to improve the efficacy of the clinic itself. We also did sit in on a board meeting, and I know from like last week when we did the clinical skills about the introduction of community health centers, and in order for it to be a federally qualified community health center, a fraction of the board has to be the patient, so it really is patient-centered. And what else? Oh, once a week I would shadow one provider. I got to shadow an NP, and she was awesome. She would help me figure out, or she would ask me what I would think, like my plan and what I would do for physical exams. So that was really good in practicing and refreshing my skills. Other than that, yeah, I also had a great time exploring Seattle when I didn't have to work on my project.
So I stayed here in LA. I was in Ultimate Health Services. They're the largest federally qualified health center in the nation. So that was pretty cool to know, and I was surprised I didn't know about them beforehand. In 5 years, they've been doubling every 5 years. So in 5 years, they're expected to become $1 billion organization. So definitely keep it out on the radar. They're looking for providers, and they do qualify for federal and state loan repayment, and I think also NHSC. And I think one of our recent graduates just got a job there. I was there during her interview, so that was cool. Anyways, so I thought this was a really great opportunity. I also had the chance to meet with a lot of CEOs and presidents. I met with Castelo de la Rocha. I met with the president of other clinics also, so Watts, Eisner, St. John's. So it's really interesting just to get their perspective on the healthcare landscape and how, where they think it's going in the future. I also shadowed in a clinic. It was cool because the PA that I shadowed, she actually graduated from this program in the 90s. So it was nice to make that connection with her. All of the patient encounters were in Spanish, so I was able to get a little more exposure in that sense also. And in addition to the clinical rotations, I had the chance to visit their different services that they have. So they actually provide a lot of different services for all their different patient populations. So they have like child obesity programs, adult obesity programs, they have Zumba classes in all of their clinics, HIV clinics, and all of that good stuff. So, and on top of that, this was my project, which I was able to make a poster on. It was assessing the barriers to utilizing the YMCA diabetes prevention program. So obviously the diabetes epidemic is a major health concern. 29.1 million people have diabetes and 86 million have pre-diabetes, which was my focus for this project. So the YMCA DPP, it's an evidence-based program that reduces the risk for type 2 diabetes by 58%, which is really significant, I think, but it's highly underutilized. This entire year, Ultimed wasn't able to produce any patient referrals to the program, even though their patient population has about 70–80% pre-diabetics. So my goal was to find out why they weren't making referrals and why patients weren't enrolling in the program. So I developed two surveys, one online survey for medical providers and staff and a paper survey for patients. And basically my major findings was that the providers and staff basically just aren't informed about the program. 74–88% couldn't identify correct program goals, qualification criteria, cost, and they didn't know how to make the next-gen referral process. Additionally, for patients, they identified costs as a major barrier. 73% said that they would only participate if their health insurance covered the costs, but none of their health insurances cover the cost, so that's a major barrier for them. But 89% said that they'd be interested in participating, which was a big positive. So based off of that, my recommendations were obviously increased training, more patient education, improving the referral process. So I was able to go to Florida, like Dr. Henry said, to present this. It was a really cool opportunity. I was able to meet a lot of the GE and NMF stakeholders, and just being there with the other students also was a good experience.
for Nicaragua, really quick, we went down there just over a week. And some of the areas that we worked in rural areas, clinics, retirement homes, and also in the primary school, we did health education programs with them birding. So the health education programs, these were just the different days that different groups covered with his kids. Anything from health education?
Yeah, we went to, I think everybody went to an elementary school. We're working with smaller children, and our project with Wilson, we came up with a poster board, and students were identifying different organs, and it was funny that the younger students were actually identifying more than the older students were, because we worked up to 5th grade. So it was a good experience to get them interactive and learning what each of these organ systems do and how to protect the organs as well, because a lot of people down there have chronic kidney disease over there. And due to the dehydration, like we're learning, and a lot of, they drink a lot of soda as well, so we taught them how to eat a little bit healthier, and it was a good experience with the kids.
Then we went to the different homes, and we put pesticides in the water, because they had a lot of them had like dengue fever and something, it's called chikungunya, which is more of a chronic problem there. It's related to dengue. So we're putting stuff in the water, we're educating the families about the causes or what signs and symptoms to look for, which is like fever or any joint pain. We also get a chance to just shadow a lot of nurses in the clinics. So I was able to do a lot of injections, and I watched a couple of pap smears.
Yeah, we also looked for, I brought the little flyers to the because they really want us to know about the epidemics that they have down there, which is the chikungunya. And then they're also looking for chinchas, they're called, who are also like bed bugs, but these were really harmful bed bugs, and they showed us, you can't probably read the Spanish, but there's pictures in there. There's certain bed bugs that they have that bite through your skin, and they leave larvae, and when you scratch it, it gets into your blood system, it can enlarge your heart, and you can pass away from that. So it was a good educational experience because we thought it was just going to be medical, but we're on accident implemented into like the public health section of their clinics. And it was the most amazing experience we could have had, because now we're seeing what directly affects these people and why they're ending up in these clinics. And so it was a good experience to help out those people and realize how open they were to their homes and how much they wanted us to know about their epidemic that they have down there. So it was good.
Yeah, we were also able to do a lot of home visits. So we were sitting in the back of a truck. There was 6 of us. We were sitting in the back of a truck, drove about 45 minutes up the mountains, and then we set up clinic at someone's house. And from there, patients would come to us, and the doctor would check them out. And then towards the end, we would hike to other people's houses, which is about a mile and a half away, just to check to see them. Because these are people who have disabilities, they're unable to go to the clinic. So I guess it was kind of nice for the medical providers there to go visit the people and treat them for their chronic problems.
I guess I'll go. So basically, during the day I was in a small health center and didn't do much there. And basically shadowed a lot, saw blood draws, followed a pediatrician or a pediatric nurse who taught us a lot about what they're trying to do there. And the cool part was at night I got to work in the hospital a lot, and so I jumped on that opportunity and worked in the emergency room where, you know, resources are just not there, not optimal. It's not very clean. There's just blood on the ground all the time, and like the staff it's hard to get in there because, you know, they don't know who you are. You don't really speak the language. So if you can, like, I was able to communicate a little bit and say like what I want to do, I want to learn. I just began by picking up trash, and once they saw I was like doing even that stuff, they're like, okay, you know, watch this or do this. So the highlight was like after like the 4th or 5th night of being there, I finally got to do like some sutures on this young guy's eyebrow, like red rub eyebrow. So that was fun. No idea what I was doing, but the nurse came over and helped me. So that was like, I was like already 1 stitch in, and I'm like, okay, do I tie this knot? Like, how do I do this? So he walked over and walked me through it. Dane got to anesthetize first with lidocaine, so that was cool. And they were doing like closed reductions for like shoulders were out of place, and they were just doing closed reductions on kids. So we were like holding traction while the doctors are like pulling, and the kids are just screaming. So they do this, you know, in like when I worked in surgery, they would do closed reductions under general anesthesia, so because it's really painful. And the kids just screaming. They like have him reset it in a chair on his own. So they did a few of those, and that was pretty wild to see. So I had a good time.
So I was working in Palmyra with Joe, Audrey, and Jackie was there for the day, I believe. And most of the time I was doing consults, especially in the beginning, because I don't think they trusted me, and my Spanish is very limited. So a lot of it was just sitting and watching, and then Joe and I realized that we actually wanted to do something, we had to be assertive about it. So we asked them, hey, where are the blood draws at? Where are the immunizations at? And then they're kind of like, okay, what can these guys do? And then we went in there, and Joe was a little shaky, I was a little shaky, a little nervous. But after the first couple, they started trusting us, and then it became a regular thing where we were in there doing blood draws and doing wound care. And that was pretty much the bulk of my experience there. What I found really interesting about Palmyra was they had the resources if they wanted to sanitize as far as blood draws. I mean, in America you get the Sani wipe, the Alprep, and there they just have just the cotton ball, nothing on it. They just take the cotton ball and just rub it on there. And that's granted after they it's like a sheet of cotton, and they take their bare hands and rip that off to make the cotton balls, and they're not wearing gloves. And I see the alcohol there, and they're just not using it. And so part of that was us educating them on why they should be doing that. And then, yeah, I guess that was, I got to also, as John said, assist with the anesthetizing the wound, but after we actually learned how to do it in class, I realized how terrible that kid's experience was. Well, I say how terrible his experience was, but in reality, that's probably better than he would get in a lot of places around the world. He left there with his wound closed, and hopefully it didn't get infected, so we did the job that we came there to do. Oh, no. Oh, I wanted to also mention that for anyone who wants to do this in the future, my Spanish is very limited. I took French in high school. I have like a year of Spanish under my belt. So I was really uncomfortable with communicating with patients, but I found at the end of the trip that it was just the idea of just putting myself in a situation that's uncomfortable that I found beneficial. Because I didn't learn how to speak fluent Spanish, but I got used to the idea of just not being like okay with the situation I'm in, because I know as future providers, even if we are speaking the language that the patient speaks, we're still going to be placed in like really uncomfortable situations. So I actually had a doctor who was like, okay, it's my first day, and I couldn't understand a word they were saying to each other because they were doing the consult. And he walks out, he's like, you're the doctor now, and I'm just like, and I look at the patient, like, hola. Yeah, that was terrible.
I shadowed a vaginal birth and a C-section. The vaginal birth was one of the most traumatic experiences. It was really scary, but good. The bed looked like a torture device. It was a bed with these two metal poles that curved like this. So that's all I could do that. The C-section seemed more professional to me. The live birth had the doctor and the nurse, and that's all. They like threw the baby out. They were like doing this with it. It was just I was really concerned.
Peligro, cuidado, aguas. La rosa viene sonando, cumbia bomba de la ciudad. La rosa viene danzando, en la cumbia que va a explotar. Solo allá que hacia atrás no está triste mi compa. Venga acá a bailar, que aquí tiene su lugar. Ponga la rocola la que más te va. La sabrosa se dejó tocar, y si tiene jugo para sabrosar, la dolencia se le va a acabar.